Nice. So in our practice, we do a lot of swapsies, and so we do a lot of complex anterior segment work, and that often means that we invite a lot of trouble, a lot of high maintenance patients into our chairs. Because the boss can handle it, and so with those IOL exchanges, there's many different reasons that we can do these, and essentially, I want to talk to you about what happens when it doesn't work out. So reasons that we can consider an IOL exchange, there's a few different ones. I mean, we think of the usual suspects, things like positive dysphotopsias, so things like halos, glare, starburst, things that come with usually multifocal or full range of vision IOLs. But of course, we can't discount, the positive dysphotopsias that can come with other IOLs and negative dysphotopsias, which often come in the form of those kind of horse blinder, temporal shadows that we see. Other issues that have kind of come up more in the, last few years, IOL technologies have come such a long way. So we see some of the upsides, but unfortunately, there's no such thing as a free lunch. You're going to manipulate light. You are going to get some of those downsides, and sometimes they're not as specific as a halo or glare. There'll be things like, vision's just not quite crisp, or you are kind of suffering from that contrast loss. Despite the fact that the manufacturer's MTF curve or defocus curve is going to show you that, it's not clinically significant, it is if it's in your chair. So that kind of not crisp quality, the quality of vision is not up to scratch for the patient. Refractive elements. So sometimes we don't always hit our target, and for whatever reason, other enhancements, corneal refractive enhancements are potentially not possible. So IOL exchanges come in handy there. And of course, we get the odd, pacification or calcification, of an IOL. So I guess the cases that I want to share, one where, maybe it is the IOL and one where maybe it's not. I think this is one that kind of we want to take a step back and make sure that the IOL is actually the problem. So that's kind of what I want to share with you guys tonight. So this is kind of your usual case. So case number one here is a 35-year-old male, so maybe not all that usual, quite young for an IOL, referred from elsewhere for a multifocal intolerance. So when you guys hear multifocal intolerance, what do you sort of think? I'll go to Becky.
Yeah, it typically means to me halos, that they're not able to function in some sort of lighted condition with what they need to do every day, and they're just very frustrated. They've tried a couple different remedies and nothing's getting better. Typically I'll try to give them 1 to 2 months to adapt, um, and then consider an exchange.
How about you, Nick? What's your MO on these?
Yeah, glare halos that persist after you've tried everything else after a few months. So neural adaptation can take anywhere from 3 to 6 months. If it's been a solid, 2 to 3 months at least, and we've already tried to optimize the ocular surface, the posterior capsule is clear and pristine. We know that's not an issue. Kind of rule things out, then I'm starting to think that this is an intolerant patient.
Yeah, and I think that's exactly what happened here, where, this patient had come from a very high volume, great refractive practice where they'd done everything. So the patient had a refractive lens exchange. They were previously a high myope, and really wanted to be spectacle free. Ended up having a LASIK enhancement, ended up with 3 rounds of LipiFlow. So exactly as you guys said, address all of the elephants in the room. So treat the, any residual refractive error, which, admittedly was very mild, and then really tried to hammer the surface there. And the patient just wasn't getting any better. So I think my pro with dealing with these is really dealing with that chief complaint. When did it start? The history is super important. So when this patient presented, they did actually have a little bit of PCO. However, those visual quality concerns kind of came up from post-op day one. And they did not get better. 2 months, 3 months, 6 months. And so by the time they ended up in our chair, they were rating that halo 5 out of 5. What do you guys think about having that sort of, numerical rating system for your symptoms? Do you use something similar? Bobby, how about you in your practice?
I mean, I think the biggest thing is just being able to track it over time. I think especially working in a practice with multiple doctors, being able to, I feel like just like corneal ulcers where you're like pain and light sensitivity, rating them on a scale of 1 to 10 and you track that over time. It can be really helpful for these patients because you think like there have been studies that for sure have shown people can neuroadapt and it takes 6 to 9 months. They've done functional MRIs where they look at people's frontal and parietal lobe and you can actually see that it gets better over time. So if we're getting to month like it's the same as it was day one and you're at month nine, you're starting to think, okay, maybe it's gonna stay like this.
I think you're
Yeah.
right though. I mean, I knew it's kind of a binary question. It's did it exist on day one and is it the same or has it gotten better? And if it's the same, then the one thing that's different in that period of time is you have a new lens. dry eye, ocular surface will improve. PCO will get worse. And so things kind of fluctuate over that time. But did that start on day one? Because if it did, then you probably do have an intolerant patient.
And that's exactly it. It's kind of this fact-finding mission where you're sort of playing 21 questions. So first it's what are your symptoms? Then you got to
Mhm.
grade them. You got to find out when they happen. And then if you've had, other, interventions in that time. So post LASIK enhancement, the patient did say you got a little bit of extra clarity, but zero change in the dysphotopsia. So
Mhm.
yeah, maybe the refractive error was contributory, but not the main issue. And so it's kind of teasing that out, which really these patients do need a lot of hand holding, which I think is, kind of the name of the game with refractive surgery, but maybe even more so in these unhappy patients. The variable with this gentleman was that he was so young, right? So of course, night driving, he's traveling, and he's just like he's had, intervention after intervention, and he's just like by the time he's ended up with us, he's just, he's super, super distraught. So he was really, really looking for a solution. So this was the biometry that was sent. And so, when we do our lens calculations for exchanges, of course, they get infinitely more complex. And so we do want the pre-op biometry. So this patient's biometry was sent here. There's a lens star, and it kind of shows you what was used there. So you can see that they are pretty high-powered lenses. So the patient was pretty hyperopic. And so, ultimately they did well, but they couldn't live with the dysphotopsia. So despite the fact that they were spectacle-free, they weren't super happy for those reasons. They couldn't do the things that they wanted to do. Some of the other testing that we use. So, we look at this is an HDA analyzer looking at light scatter, looking at that ocular index there. So we talked about the patient having had, a number of rounds of lipoflow. The surface didn't look too bad. And you can see here there's not a ton of light scatter. And, you'd almost expect for patients with dysphotopsia to have, some amount of something to be able to show them kind of objectively on scans. I've worked in practices where we've used an eye trace, and I find that to be super, super useful. What do you guys use to kind of judge the kind of non-Snellen acuity, more quality of vision, whatever you want to call it? How do you judge that?
I like eye trace. I mean, eye trace is really nice because you can also separate, what the cornea, and so sometimes in these cases it is really nice. There's a few other ones that are out there. HD Analyzer is nice. HD Analyzer is nice. The other one I used was the Antares. It's made by CSO. Now they have their epithelial thickness mapping OCT. But those can be really nice just to get an objective measurement of what the patient's seeing.
I
Yeah, we
agree.
use a wavedyne, and we've also used a Nidec OPD.
Yeah.
Yeah.
Very similar. I mean, you're going to look at the higher order aberrations on the Zernicke profile, and it gives you more of a qualitative view in a numerical sense.
And these will often light up like a Christmas tree if you have something like an opacified lens. But with something like this, where it's a perfect surgery, it's beautiful. I'll show you some images in a second. You're like, everyone else would look at this and go, well, it's perfect. Leave it alone. You're happy you're not wearing glasses. But, as we said, the patient's not so happy. So this was, we got to do our due diligence. So we go layer by layer. So the cornea looks good, nice, healthy endothelium there. We looked at the surface, was not having any issues. Going further back, you got pictures of the nerves there. So there's a compass visual field, which gives us that beautiful image there. And you can see nice clean visual field. We've got our UBM there. Again, beautiful surgery, everything beautifully centered, no tilt, no reason for anything to kind of be an issue there. You've got your multifocal full range of vision IOLs there. It's pretty clear there. Maybe a touch of PCO, if any. I think that would be almost an argument to make there. But you can see that everything's just you got to check off each one of those boxes. And already, we're thinking down the same line here, just looking, just based off the history. You could almost do it based off of that, but you got to do your due diligence here. And so ultimately for this patient, we did end up doing a bilateral IOL exchange for a non-diffractive EDOF lens. So this particular lens is a pure C. So I know you guys have been asking me about this. We've had this in Canada for about a year now. And it does look like that. It looks like a monofocal. So this is the pictures of this patient. In that second, in the image right in the middle, I don't know if you can sort of barely see that little, it's almost got like a little wave. You can see it under the surgical scope. Behind the slit lamp, it's very difficult to see. So it does look like a monofocal. And like many of this kind of style of lens, like we did with Vivity, same thing. We have that little myopic offset that we did for this patient to try and keep him as spectacle free as possible. Of course, you want to manage those expectations. You don't want to kind of go too far down that path, but ultimately this patient was thrilled. So that's his post-op UBM there. Beautiful surgery, 6 weeks post-op. He's 20/20 at all distances and just super, super happy and over the moon. So, this one was your typical. So that's a happy ending, multifocal intolerance by the book.
I think we got to go back. One thing that I do, I consult with surgeons, and they'll be really quick to pull the trigger on a YAG, even if there's like arguably like a little bit of PCO, but really not much. I mean, looking at those pictures, that looks super visually insignificant. So going towards a YAG doesn't really make sense. I think that's really just kind of buying time. Now, the problem with doing a YAG in this case is that now you've got an open posterior capsule. You have nothing on the front, you have nothing on the back. You've got just kind of a girdle holding that lens in place. Getting that lens out and replacing it becomes much more challenging and it becomes a lot more risky. You're asking yourself, there could be vitreous prolapse, there could be retinal detachments. That becomes a lot more challenging. Now, certain surgeons are more comfortable than others, but in my experience, doing a YAG when you're really not confident that that is the problem is kind of a foolish mistake to make.
Yeah, I completely agree. It's interesting. I've worked with surgeons and they've wanted to be really, really slow on pulling the trigger on a lens exchange. Very, very slow. 6 to 9 months. Like you stated, Bobby, those articles are obviously convincing for a reason. I mean, it's real. We can neuroadapt. I've had a handful of patients that I've recommended an exchange on, and I felt like by week 4 to 6, I knew that they were not going to adapt. And I walk with them. And these are patients, I don't know what you guys typically do, but I'll see them back once a month to gauge where they're at on the scale of frustration. And if it's pretty consistent, typically they know and I know by month 2 to 3, we want to consider an exchange. And I'm with a surgeon who wants to be willing to exchange a lens, but doesn't want to, like you said, Nick, let that capsule get so contracted that, PCO starts to become an issue and it becomes harder to tease it out, which goes back to your original point, Anu, of asking when did the symptoms start? But we definitely like lens exchanges on closed capsules. Anu, are you guys doing a lot of open capsule IOL exchanges? Yeah.
Yeah, there's not a lot we want to. Maybe a little different cross section of the realm.
I had a patient this week who came in, it was a younger patient who had cataract surgery. She was like, yeah, my light sensitivity at night is just getting worse. She had a monofocal lens and comes in and her posterior capsule looks very clear, but she has glistenings, which can happen in that Acrosoft yellow Alcon material. And she had just seen two ophthalmologists and they had said like, okay, yeah, we can do a YAG. And she was like, okay, well, do you see a lot of, fuzziness? And they're like, no, we don't really see it, but let's just try it. And she's like, I got to get a third opinion. And so then, it's just interesting, I think Becky, it's really interesting, and I think we could debate this, but I'm really a fan of letting people neuroadapt. Like the literature shows people can neuroadapt, but everybody's different, and it's a tough decision when patients are coming in like, oh my goodness, I cannot do this anymore. And as a doctor, you want to help people, so then you're like, gosh, I know you can neuroadapt, but it's going to be another 6 to 9 months. And they're like, another 6 to 9 months? I don't know if I can live another month like this. It becomes really challenging when you're talking to these patients because ultimately at the end of the day, we just want to help people.
Yeah,
I
Yeah,
think
you
you're
said
really
it.
find.
trying to help
Oh,
them. Like you're not trying to brush it off. I think they do respond. And when you can kind of say, are you improving? Now, I'm not expecting it to be perfect and be gone, but is it getting, today versus when I saw you, like you said, Becky, a month ago or 2 months ago, is it any better? Can you do anything more than you could? And also, honestly, scaring them a little bit, where patients are kind of looking for that magic bullet and they're sort of like, they want everything, but they don't want any of the downside. And as we said, you can't cheat physics. So I often will say to patients, listen, Mrs. Jones, you're not wearing glasses anymore. You used to wear them 110% of the time. You're not wearing them all at all. Yes, you've got these symptoms. Are you willing to give that up? Is this so bothersome to you that you'd be willing to have a monofocal lens and wear glasses for everything that you can touch and then kind of name off those things just to kind of put it into perspective? Again, not to scare them, but just to make it real. It's a big surgery having an IOL exchange, and of course we do them, but I think kind of just playing ball with the patient and really kind of getting them on board and making sure that they feel cared for, that they feel that you're doing everything you can and taking every step that you possibly can. I think it helps.
Right, because I knew not every patient that you do this strategy in, where you do like a mini mono vision or a blended vision with a little bit of offset, ends up like this, right?
Exactly.
There is definitely some that you do this and they're like, I can't see anything up close, So I think it's great that you just set the expectations and then ultimately at the end of the day, let the patient decide.
Well, and we also have a backup plan, so for this patient, for any patient, this one has a, closed capsule, but ones with open capsules in particular, that backup plan really comes into like, this is in the realm of possibility where we have to maybe put in a sulcus IOL or put something in reverse optic capture, and that's a monofocal. there's no toricity, there's nothing there. So, and you may or may not be able to get away with any monovision. So those have to come into play for the patient as well.
I don't know, Anu, I don't know if you know this I don't know if it's like this in Canada, but in the US, and maybe Nick was about to say this, now we got LAL in a zero powers lens. And so you can actually put it in the sulcus
It'll
and have the
piggyback.
ability to add some toricity or to bring them in. Or I had a patient who's post myopic LASIK who's ended up with a big miss in one of the eyes, and she like doesn't want PRK, she doesn't want a lens exchange. She's like, what other option is there? And I'm like, oh, actually now, right, Nick?
Ding, 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 ding. You got it.
You got to hear the pro.
Yeah.